Good morning, everybody. Good morning. Today we will discuss questions of radiology from this November AIIMS. I will also discuss what else can be asked about these questions, and I will pick up. Good morning. Yes, and I will pick up a few questions from May AIIMS as well to show you what was asked in AIIMS in May and what was asked in November, and I'll discuss all the radiology questions. I know some of you are facing an issue with the test paper. Don't worry, we have a strategy in mind. After each session or after today's session, you will get the questions which were discussed today, and after tomorrow's session, you will get questions which will be discussed tomorrow, so that you have an idea what was discussed in the class and you can revise back at home. Reason we are doing this is because our teachers are still in process of connecting the entire recalled question to the perfection. We are trying to make each question with the entire 4 choices as it was there in the AIIMS paper. Okay. Now let us look at the first question. This is the first question from radiology, which was a repeat from previous year's exam. Okay. A 32-year-old lactating female presents with a painful palpable lump in her left breast. What is the most appropriate investigation to diagnose her condition? Now what do you think? What do you think? Now my thought is, please look at the keywords. What is the first keyword in this question? Young female, 32. Second, okay, some of you are saying, sir, young 30. Oh, 32 is young. Okay, don't worry, 32 is still young. Okay, lactating female, lactating. So lactation is a risk factor for breast abscess. Now look at this third line, painful lump. Again, what we are thinking? Breast abscess. What is the most appropriate investigation? Answer is, please remember, ultrasound. Okay. Now, what else do you think would be the question in which the answer would be ultrasound? If they will ask you a question, how to differentiate between a solid and cystic breast lump, then you will mark the answer as ultrasound. Okay. Are you able to understand this? If they are suspecting abscess, answer is ultrasound. If they are suspecting solid versus cystic, ultrasound. Okay. In which questions the answer would be, tell me, in which questions the answer would be mammography? Now tell me. Mammography, please remember a few questions which are likely to be asked in your exam. Is the screening investigation of choice for ductal carcinoma in situ. Mammography, screening investigation of choice for ductal carcinoma in situ. But please remember a question from November AIIMS 2010. It is not the most sensitive investigation. If they say most sensitive test for ductal carcinoma in situ breast, if this question gets repeated in the AIIMS, please remember you have to mark the answer as MRI. MRI is the most sensitive investigation for ductal carcinoma in situ breast, but routinely not recommended for screening. Is that making sense? Now, please understand the difference between routine screening and high risk screening. Routine screening is done after the age of 40 years, annually. 2 questions, annual after the age of 40 years, and it is done with mammography worldwide. Okay, routine screening is done after the age of 40 years, annually by mammography, while high risk screening is done by MRI. Okay, let me repeat. Routine screening everywhere in the world is done by mammography. It is done after the age of 40 years. It is done annually. 3 questions. But high risk screening is done in females who are genetically predisposed, or can you tell me, or who are having a family history. Then we will do high risk screening with MRI. Okay. Now let us go back to the first slide again. Okay. Now, okay. Now the first question that I was discussing was 32-year-old lactating female, painful lump. What is the most likely investigation? Ultrasound, because we are suspecting Doppler, because we are suspecting abscess. If we were saying screening, routine screening in a 40-year-old female for breast cancer, we will mark mammography. If they say most sensitive for ductal carcinoma in situ, mammography. Most sensitive, MRI. Okay. SPECT is not indicated for breast in any indication. So is that clear now? Okay. Now let us look at the next question now. Now to increase your size, just let us do this. Okay, there are two questions this year in AIIMS. Okay, there are two questions this year from AIIMS which are based on a topic called as fast. There are two topics from the topic called as fast. Now let me explain to you what is fast. Okay, now what is fast and why they are asking this question again and again? Recently in AIIMS they have started a course for general physicians for fast. Now please see, fast was started for general physicians. This is a type of ultrasound which is taught for general physician in AIIMS. Let us remember a few things. First, fast stands for focused assessment with sonography in trauma. Can you remember this? Focused assessment with sonography in trauma. While many people will still not remember what I am trying to say. Okay. Okay. Is that making sense? Many people will still not remember. The question was simple. FAST word stands for focused assessment with sonography in trauma. Okay. Can we see this again? Okay. Now let us remember this. Okay. Okay. Let us remember this. Fast is done by, let me tell you a few key points, done by general physicians, not by radiologists. Do not mark radiologist. Fast is done in how much time? Only 1 minute. Fast is done in 1 minute. Fast is done to look for hemperitoneum. Please remember three keywords. Fast is done by general physicians who are posted in trauma. It is done within 1 minute. It is done to detect hemperitoneum. Now let us understand this further so that you can get more questions. Now where do you keep the ultrasound probe when you are doing fast? Where do you keep the ultrasound probe when you are doing fast? If suppose this is the abdomen of the patient, okay, first we keep the probe in the right hypochondrium, or they may say right lumbar region. Are you able to remember this? While doing fast, you keep the probe in the right lumbar region. Now what is there in the right lumbar region? What organs do you see? Liver and kidney. Okay. What organ do you see in right lumbar region? We see liver and kidney. So what is between liver and kidney? Can you tell me what is there? What is this area called as? Pouch of Morrison, which is also called as hepatorenal pouch. Please remember, right lumbar region, we first keep the probe. This is a very important question, was asked in the last All India as well. While doing fast, where do you keep the ultrasound probe first? What is the answer? Answer is right lumbar region, to look for blood in the Morrison's pouch. Okay, first question. Second question, where do you keep it next? We keep the probe in the epigastrium. Now we keep the ultrasound probe. After first we kept in the right lumbar region, then we keep in the epigastrium. Now when you keep the ultrasound probe in the epigastrium, we tilt the probe upwards to see the pericardium. Now imagine a patient who comes to you with road traffic accident, and there is blood in the pericardial area which is not allowing the heart to contract. What do you call this? Give me the name. Cardiac tamponade. Now I will tell you a new question which everybody will get wrong. Only you will get correct. Question is, fast is done to look for hemoperitoneum. Choice number 2, hemoperitoneum with cardiac tamponade. Now what will you mark? Answer is cardiac tamponade. Please remember, we look for both hemoperitoneum and cardiac tamponade. Although this question has never been asked, but whenever it will be asked, only you will get it correct. Now let me repeat. FAST is focused assessment with sonography in trauma. First step in blunt abdominal trauma evaluation, done by a general physician posted there, done within 1 minute, okay, and the probe is first kept in the lumbar region on the right side to look for Morrison's pouch, okay. Then we keep the probe at epigastrium to look for cardiac tamponade as well. Then we move the probe to the left side over the spleen. So what will I write on the notebook? We will keep the probe in left hypochondrium. You will keep the probe in left hypochondrium to look for spleen. Normally spleen is ruptured. So if there is splenic rupture, there would be blood around the spleen. So we keep the probe in the left hypochondrium and look for perisplenic hematoma. Perisplenic hematoma. And then we keep the probe at the pelvic area to look for blood in the pelvis. So please remember this very important question, difficult for undergraduates but very often asked. 4 places you will keep the probe while doing FAST. Right lumbar region, epigastrium, left hypochondrium and pelvis. Okay. Now let us understand one more concept. Now what AIIMS people are asking is a new question. Now they are asking about E-FAST. Many of you would have given my test so far. Some of you are yet to give. Please remember, E-FAST stands for extended fast. Extended fast. Now what we do is, after doing fast, this is first time in 2013 they have asked a question on extended fast. Please remember, after doing fast, you keep the probe on the anterior chest wall. Okay, after doing fast, you evaluate the chest as well. Okay, now think and tell me what can happen to the chest in a patient with abdominal trauma. What can happen? Pneumothorax, hemothorax. Okay, so if they say what do we do in E-FAST, in addition to the peritoneal cavity, you also evaluate thoracic cavity. This is the latest trend which they are asking today, because this is what is recommended worldwide. Now please remember, how do you identify, now this is something very interesting I'll teach you now. How do you identify pneumothorax while doing fast? How do you identify pneumothorax while doing fast? First question, which mode of ultrasound do we use while doing thoracic evaluation in fast? Okay, which mode? Now please remember this, M mode. Okay, when I do a normal M mode ultrasound, what do I see? When I do a normal M mode ultrasound of the chest, what do I see? Please remember this very carefully. I will see the chest wall, I will see the pleural interface, and then there is lung. Okay, on ultrasound, this point where pleura becomes lung is called as lung pleura interface. Lung pleura interface. Now please remember, lung pleura interface on normal M mode ultrasound is called as seashore sign. Okay, so what will you get in your question as an exam question would be, a patient has road traffic accident, extended fast was performed and seashore appearance was absent. What is the diagnosis? Pneumothorax. Are you able to understand? Normal lung pleura interface should show an appearance called as seashore appearance. If that is not seen, it is pneumothorax. Now let us look at one more question. If there is pneumothorax, what do you see? You will see the chest wall. Then there is air, no lung, no pleura, only air, like this. You will not see the pleural interface, only some air shadow like this. This is called as stratosphere sign. Stratosphere sign. When was this asked? November 2013 AIIMS. A patient had road traffic accident. You did a M mode ultrasound which showed stratosphere sign. What is the diagnosis? What is the answer? Pneumothorax. Now let us look at the questions again. Let us look at the questions again. Okay. Now look at this question very carefully. FAST stands for focused assessment with sonography for trauma. Okay. Please remember this. Focused assessment with sonography for trauma. Okay. Now look at the choices. They are saying focused, fast. Now please do not get confused. It is focused. Okay. And the next question that I was talking to you about was, give me just 1 second. I'll just increase the font for you. Don't worry. Okay, this is the question that I was talking to you about. First time in AIIMS, a question on extended fast. A person had road traffic accident, brought to emergency department, respiratory distressed, reduce SpO2, M mode ultrasound of the right chest reveals stratosphere sign on M mode. What is the diagnosis? Please remember pneumothorax. Now let me tell you two questions now. Absence of seashore on M mode ultrasound indicates pneumothorax. Now please remember again, presence of stratosphere indicates pneumothorax. Now are you okay with this now? Okay. Now let us look at the third question now. Now this is very simple question, very unlike AIIMS that they have asked, but just to show you the question, then I'll tell you what will they ask next time. Okay, look at this question with me. In contrast-induced nephropathy, which of the following indicates renal impairment? Okay. Now I think looking at this question, okay, if please see it very carefully. Even second year MBBS will say answer is increase in serum creatinine, because renal impairment would not be told by bilirubin, and decrease or increase, I should choose increase. Okay. But I will tell you what they will ask next. They will understand when everybody will get right. They will not repeat this question. Next time the question will be something else, which I want you to look at this question with me. Give me just for 1 second. I will predict the next question with you. Okay. Now let us look at the topic called as contrast mediated nephropathy. Okay. How do we diagnose this and what is this? Now what is contrast? What contrast do we use in CT scan? Iodinated contrast. So whenever you give iodinated contrast, there are chances that the patient will develop nephropathy. Okay. Now in which patients there is more chance? Please remember, diabetics are at a high risk for nephropathy, as are people with multiple myeloma, as are people who are dehydrated and pre-existing renal disease. Okay. Now again, the next question that you will get in your exams is, which of the following patient is at increased risk for contrast nephrotoxicity? What is the answer? Answer is diabetics, multiple myeloma, dehydration, pre-existing renal disease. Okay. Now if you go back to see your guides, there is a question which was very tricky for everybody. There is a question that you were asking many times. Which of the following is an absolute contraindication to iodinated contrast? Please remember, these are contraindications, but they are not absolute, but these are contraindications. You should always remember. Diabetes is a contraindication to iodinated contrast, multiple myeloma. But we can use certain precautions to prevent this. So this is relative contraindication. I'll repeat. Okay. Now question that you will get in your exam next time is, how do you diagnose contrast nephropathy? How do we diagnose this? How do we diagnose? Tell me. The question that they have asked this time is, when we see rise in serum creatinine, rise in serum creatinine indicates contrast nephropathy. Yes, yes. But next time they will not ask this. They will say how much rise. Please remember, at least 25% rise. This is the next AIIMS question now. At least 25% rise in serum creatinine on the third day indicates contrast nephropathy. Are you able to follow this? Now please see, I have to think faster than the examiner. Last time they have asked, when do you say contrast nephropathy? When there is rise in creatinine. Next time they will say creatinine rise more than 50%, more than 25%, more than 30%. Now what is the answer? More than 25%. Okay, and this is measured third day. Third day means today I get, okay, I will come back. Okay, don't worry about it. I will answer your question. Okay, please see. Please let me finish this. Today if I give a patient IVP study, today if I do IVP study, I inject contrast today, first day. Tomorrow, day after tomorrow, I have to measure the creatinine level. If it is more than 25% rise, that is called as contrast nephropathy. Another question which has not been asked here, which is likely to be asked, is contrast mediated nephropathy is, please remember, transient post ischemic, okay, it is transient non-oliguric type of nephropathy. This is the question that you will get again. When you get nephrotoxicity because of iodinated contrast, it is a transient phenomena and it is without oliguria. Very important. Okay. And third question, which is very often asked in AIIMS, if you look at your Amrita sheet, you will see so many times. How will you prevent contrast nephropathy? How will you prevent? Please remember, 1. Hydration. 2. N-acetylcysteine. N-acetylcysteine is renoprotective. 3. Can you tell me? Hydration, N-acetylcysteine. What else? Preferably use non-ionic contrast. Please remember, there are two types of iodinated contrasts, ionic and non-ionic. Out of these, we prefer non-ionic contrast for contrast nephropathy. To prevent. If the patient is diabetic, you have to choose non-ionic contrast. Okay. Third thing, please remember, very, very important. Examiner will fool you. He will write in the choice, hemodialysis. Okay, please see this question now. Previous AIIMS question. How will you prevent contrast nephropathy? Okay. And they will say all except are used to prevent contrast nephropathy. All except. One of the choice will be saying hydration, N-acetylcysteine, non-ionic dye, hemodialysis. What is the answer? Answer is hemodialysis. Please remember, hemodialysis is not useful in preventing contrast nephropathy. This is just one fact on the basis of which AIIMS people are again and again creating this question. Please remember, they will say which of the following is not useful to prevent contrast nephropathy. They will give three choices which are useful. Which are they? Hydration, N-acetylcysteine, non-ionic dye. But which is not useful? Hemodialysis. But when you have not studied, you will not find this. Okay. So these are some questions from this year. Contrast allergy. How do you prevent contrast allergy? Allergy is a different question. Nephropathy is different. Allergy you will prevent by steroid loading. Hyderabad, do you understand? Steroid loading. You will initially load the patient with steroid before doing a CT scan. Okay. That is specially done if the patient is having a drug allergy history. Somebody who comes to us with drug allergy and I have to do a CT scan, you will load the patient with steroid before you give the contrast. Okay. Okay. Again, one controversial question now. Now, many of you might have seen this question. Many of you would be seeing it for the first time. But please remember, this question was asked in this November AIIMS. repeat it as it is in JIPMER. As it is, they repeated the same question. And people who got it wrong, they got it wrong in both the exams. Can you understand double jeopardy? Do you understand double jeopardy? One question costing you 2 exams. Same question repeated again and again. Question is, increased pulmonary blood flow is radiologically indicated by all except right descending pulmonary artery more than 16 millimeter, curly B lines, diameter of the artery more than twice the accompanying bronchioles, more than 6 arteries in the peripheral 1/3 of the chest X-ray of the lung fields. What do you think? What do you think? Okay. Now, what I'll do is, I will give you an idea on what is this question all about. Once you know, you will know. So simple. Okay. This question is about a word called as pulmonary. This is about pulmonary plethora. Okay. It is about pulmonary plethora. What is pulmonary plethora? What is pulmonary plethora? Pulmonary plethora means increased pulmonary blood flow. Increased pulmonary blood flow. What is increased pulmonary blood flow? Suppose a patient has left to right shunt. Left to right shunt. What will happen to the blood flow in the lung? It will increase. It will increase. Left to right shunt. So that is called as plethora. If it is reduced, it is called as. If it is reduced, it is called as. It is called as oligemia. If it is reduced, it is called as oligemia. If it is reduced, it is called as oligemia. Okay. If it is increased, it is called as plethora. Reduced, it is called as oligemia. Okay. Now let us think of it again. Okay. Let us think of it again. Now first question. Plethora means more blood is there in the lung, which is seen in left to right shunt. Now tell me, what will happen to the diameter of the pulmonary vessels? What will happen to the diameter of the pulmonary vessels? Diameter will increase. So which vessel do we measure? We only measure the right descending pulmonary artery. We only measure the right descending pulmonary artery. Many people get it wrong. We do not measure the left side, we only measure right descending pulmonary artery because it is easier to measure. Twice they have asked this question in the past in AIIMS. Which vessel do you measure to assess pulmonary plethora? Right descending pulmonary artery. And please remember, right descending pulmonary artery more than 16 millimeter is an indication for pulmonary plethora. Right descending pulmonary artery more than 16 millimeter. Okay. Second, normally if you look at a chest X-ray, blood vessels will be seen only in the medial part. Only in the medial part. If I see blood vessels in the outer 1/3, then we call it as plethora. Third point, normally pulmonary vessel and bronchus are of same diameter. If the vessel is more than twice the bronchus, it is plethora. Now, let us look at the PowerPoint again. Let us look at the question again. Okay. Okay. Now, how they have framed the question? They are giving one choice as right descending pulmonary artery more than 16 millimeter. Correct. Correct. This is what you measure, and this is a repeat question. First choice has been asked as a question in itself. If the right pulmonary artery diameter is more than how much? You call it as plethora, 16 millimeter. Second is diameter of the artery more than twice the accompanying bronchiole. Answer is true. It is how plethora is diagnosed. If you visualize more vessels in the outer third, yes, it is plethora. Answer is curly B lines. And many people are telling you wrong. Please remember, curly B lines, they do not indicate increased blood flow in the lung. Increased blood flow is plethora. Curly B lines actually indicate pulmonary edema. Pulmonary edema. Pulmonary edema is seen in left ventricular failure. When a patient has LVF, there is increased pulmonary capillary wedge pressure, fluid comes out into the interstitial spaces of the lung, which is called as interstitial edema, seen as lymphatic engorgement, which is called as curly lines. Now please remember this. Increased blood flow, some people till today are confusing between increased blood flow and edema. And they will get it wrong in the exam because this question has been twice repeated. November 13 AIIMS, JIPMER AIIMS. This JIPMER exam this year. Please remember, curly B lines does not indicate increased flow. Increased flow is plethora, which is seen in left to right shunts. Curly B line is pulmonary edema. Okay. Now let us look at another question now. Again, one of the questions which you will find as controversial. Oligemia is when you see more black lungs. There is no criteria for oligemia. When you see less vessels, we say oligemia. Okay. Now just to look at this question. This is first time they are asking this question in AIIMS. Now let us see this question now. Okay. Different curly lines, Aurangabad. Yes, good question. Let me explain different curly lines. Okay. Take note. There are three types of curly lines: curly A, B, and C. Curly A lines are lines radiating from the hilum. Curly A lines are lines radiating from the hilum. Curly A lines are straight lines radiating from the hilum. Curly B lines are horizontal line at the lung base. And curly C lines are seen as a mesh over the entire lung. Okay. A line are radiating from the hilum. B are straight lines at the lung base. In the last All India, they had a visual showing curly B lines, and curly C are seen as a mesh over the entire lung. Please remember this word with me. They indicate interstitial edema in the lung, fluid in the interstitial spaces of the lung, or they may say lymphatic engorgement. And they have asked this very difficult question: at what pressure do we see curly lines? What PCWP? Please remember, 20 to 24 millimeter mercury is the usual pulmonary capillary wedge pressure at which curly lines appear on the chest X-ray. Okay. Now let us see. Okay. Now let us see the next question now. Now look at this question carefully. This is not your level question. You will, if you do not listen carefully, you will not get this. A 14-year-old boy with abnormal movements, MRI shows involvement of the bilateral striatum, thalamus, pons, centrum semi-ovale, asymmetric diffuse white matter involvement. What is the possible diagnosis? Now many people who read this question for the first time, they marked the answer as Halle-Warthin-Spass disease. AIIMS November 2013. Is the answer Halle-Warthin-Spass? No. What is Halle-Warthin-Spass disease? Halle-Warthin-Spass disease is earlier believed to be an idiopathic disease. Now we know first sign of pulmonary edema is, please remember Rotak, is cephalization of blood flow. More flow in the upper lobe vessels. Okay. Now please remember, Halle-Warthin-Spass disease is a disease which involves the globus pallidus. Are you able to remember this? Globus pallidus. Now here in this question they are involving the entire white matter, entire striatum, there is white matter involvement, striatal involvement, thalamus involvement. This is not Halle-Warthin-Spass disease. Halle-Warthin-Spass disease, I will again repeat, don't worry. Okay, Halle-Warthin-Spass disease is, now please remember this, a future MCQ for AIIMS, okay, future MCQ for AIIMS, which I am going to tell you. Halle-Warthin-Spass disease is also called as pantothenate kinase associated neurodegeneration. Please remember, you will not read this in Harrison's, okay. Pantothenate kinase associated neurodegeneration, characterized by involvement of globus pallidus. What do we see in globus pallidus? Iron deposition. And tell me a question from All India exam. What is the MRI appearance called as? Please remember this, eye of the tiger appearance. Eye of the tiger appearance on MRI is seen because of iron deposition in the globus pallidus seen in Halle-Werdum-Spass disease. Now let us look at the question again. Now why I am telling you this is, many people had marked Halle-Werdum-Spass because they thought longest choice will be the answer. No, not like this, don't do this. You will not get an AIIMS rank like this. Now see this. They are not showing, they have not written globus pallidus involvement, they are saying diffuse involvement of bilateral striatum, white matter. Now tell me what is the diagnosis. Now tell me, look at the third choice now, third choice, Wilson's disease. Tell me about Wilson's disease. Tell me the full name of Wilson's disease. Hepatolenticulo, then many of you are saying degeneration. No. Hepatolenticulostriatal degeneration. Now read the question again. Wilson's disease is characterized by striatal involvement. Okay, striatal involvement. And there is white matter involvement. Another point about Wilson's disease is, which is very likely to be asked as a question. Wilson's disease shows the involvement of, let me write down, striatum, white matter, midbrain. And whenever you see midbrain involvement, what do we see? Which part of the midbrain is not involved in Wilson's disease? Okay, let me show you. This is midbrain. This is crus cerebri. And this is colliculi. What do we call them? Tectal plate. Now please bear with me for 1 second. And tell me, what is this anatomical structure here? What do we see in the crus cerebri? Substantia nigra. And what is this structure? Tell me. Red structure I am drawing for you, for your entertainment. Tell me the red structure. Red nucleus. Now my question to you is, which only you will answer if it is asked in the next AIIMS. Which part of the midbrain is not involved by Wilson's disease? Answer is red nucleus. Red nucleus is not involved. So what will you see on MRI? Entire midbrain is involved. But the red nucleus are not involved. They look like eyes. And this entire thing looks like a face. So what do we call it as? Face of giant panda appearance on MRI is seen in Wilson's disease. Now let me again recap. Wilson's disease, childhood present with movement disorder. It involves the striatum, white matter, midbrain, but spares, usually cerebellum is not involved. Okay, it spares the red nucleus. This is called as face of giant panda appearance on MRI. Another question to you is, if they ask you, please see this very carefully. Please remember this, do not forget, if they say panda appearance on gallium study is seen in sarcoidosis. Please remember there are two Kung Fu pandas, do not think only one, two pandas. Panda appearance on MRI brain is Wilson's disease. Panda on gallium scan is sarcoidosis. Now, because sarcoid is going to involve the gland, so which gland? Lacrimal parotid. So how will you see on gallium scan? You will see involvement of the lacrimal gland, parotid gland, and nose. So this entire thing has been called as the panda appearance, just like this. Okay. Whenever you see high uptake in the lacrimal gland, parotid, and the nose, this is called as panda sign on gallium study in sarcoidosis. Okay. Now let us see the next question now. Okay, this I have already shown you. Okay, now this is again a new question which AIIMS people have asked in November. Do not worry about the questions too much. You will get them in the end of the class today. Reason we have not given you question right now is because I do not want your imagination to go. If I give you the question, you will say, I know I will not listen to Dr. Sumer, and you do not know that I will tell you not only the question, I will tell you what will be asked next time. Okay, please bear with me. A female got pregnant for the first time LSCS was done for fetal distress. Mild hypertension was given present during the pregnancy. 2 days after delivery, she complained of headache, seizure. CT scan shows a parasagittal hematoma. No proteinuria was seen. Most probable diagnosis is. Okay, let me repeat this everything into a slide. Okay, let me just create this question in a clinical manner. Let me just jot down what is the question all about in keywords for you. Keywords. I'll teach you keywords. Number 1 keyword, pregnancy. Mild hypertension. Look at what examiner is putting into your mind. No proteins in the urine. Mildly hypertensive. Then some neurological complaints. CT shows parasagittal hematoma. Now many people could not understand. Yes. Jammu, you're getting up a little late. I'll come back to your question later on. Yes, there is a difference between normal diameter. In females, we take diameter little less. But for plethora in general, we take the cutoff as 16. Although normal diameter in male and female is a little different. We take 1 mm less in females. Okay. Now please remember. Please see this with me. Very important. If this is, I'll teach you many questions here. If I'm looking on my skull from front, I'm looking from top, and I'm able to see within, this is the superior sagittal sinus, this is the transverse sinus. Okay, tell me, why is superior sagittal sinus called as superior? Because it is at the top. Sagittal, because it is in the sagittal plane, in the midline. Okay. Now what is shown in the question? They are saying there is a parasagittal. What do we mean by para? Para means surrounding the sagittal plane. Simple English. Para means surrounding the sagittal plane. So think of it. There is hematoma here of 2 into 3 centimeter. This is what is written in the question. Now when they say mildly hypertensive, no proteinuria, will you mark eclampsia as the answer? No. Do you think there will be hypertensive bleed? It looks unlikely because she was only mildly hypertensive. Doctor is not even sure of the hypertension. Now look at what has happened. Pregnancy is a hypercoagulable state. So what will happen to the venous sinus in pregnancy? It may get thrombosed. This is called as sagittal sinus thrombosis. Okay. Now tell me, from your clinical knowledge or your pathological knowledge, if a vein is obstructed, what will happen to the surrounding brain? If this is thrombosed, what will happen to the brain? It will show hemorrhagic infarction. Now you are all surprised because you have been taught in your medical school that arteries obstruction lead to infarct. No, there is something called as venous infarct as well. If vein is obstructed, you will have venous infarct. And in your pathology basic, when you were in second, third year, they taught you venous infarcts in the brain are hemorrhagic. So how do you identify a venous infarct on a CT scan? It looks like a hematoma. It is a hematoma like only. Okay. Now when they say parasagittal hematoma and they add to it pregnancy, I think of a venous infarct and I mark the answer as superior sagittal sinus thrombosis. This is not pituitary apoplexy because pituitary is not parasagittal. Do you understand? Sagittal plane, it is not at the top. Pituitary in the sella. Okay, pituitary is not there. Hypertensive bleed usually would be seen in putamen. Putamen would be the key word in the question, not parasagittal. And it is not eclampsia at all. The patient is only mildly hypertensive, no proteinuria. Now let me teach you one more question when we have time. Okay, please see. If I see the superior sagittal sinus in cut section, if this is brain, falx cerebri, this is the superior sagittal sinus in cut section, it is like a triangle. If there is a thrombus in this triangle, how do you identify? Please look at it very carefully. How do I identify superior sagittal sinus thrombosis? Empty delta sign. Can you remember this? Superior sagittal sinus is triangular in shape. If I cut, it will look like a triangle. Okay, now I'll tell you a very beautiful question for the next All India also. Please see. If there is portal vein thrombosis, how do you identify on a CT scan? Now you will be surprised. If there is any vein, if I cut it on a cross section, it will look rounded. And if there is thrombus inside, it is looking like this. Venous thrombosis on a CT scan is called as polo mint sign. Okay, now let us see the similarity. You must be wondering, what am I saying? Please see. It is all about cross sections, because MBBS students are not, they do not know cross sections at all, they cannot understand. Please see. Superior sagittal sinus, if I cut, it is triangular. That is why the MCQ is saying delta, delta. Okay, please remember, it is saying delta because it is triangular. A normal vein, if you see in cut section, it would be rounded. If there is a thrombus in superior sagittal sinus, we will say empty delta. If there is a thrombus in a normal vein, we will say polo mint sign. Again, you will be surprised to know this is the question from All India PG 2013, which they have asked, and very few people know this. Okay. Now let us move on to the next question. Superior sagittal sinus is mostly thrombosed, but I think let us put this question to ENT people better. That would be better. Now I want to do some controversial questions from May AIIMS, which I know are wrongly answered in your guidebooks. And if you are seriously appearing for this AIIMS, I want you to get an advantage. Just bear with me for 1 second. Which of the following is not seen on ultrasound in acute pyelonephritis? Grossly enlarged kidney, focal areas of hypoechogenicity, perinephric edema, increased vascularity. In your guidebooks, please trust me here, this question is still wrong in every book that you have bought in the market. It is wrongly answered everywhere. Please remember, the answer is increased vascularity. Okay, let me explain to you. Now you are all surprised, so now I will help you. Okay, give me just 2 seconds and I'll tell you so many questions which they are asking nowadays. Okay, now this patient has acute pyelonephritis. Acute pyelonephritis. Let me explain to you in 2 minutes. Acute pyelonephritis. What will happen to the kidney on ultrasound? It may be normal, may be enlarged. What will happen to the surrounding tissue? What will happen to the surrounding tissue? There will be perinephric edema. Correct, because there is inflammation. Perinephric edema. What will happen to the kidney tissue? Let us see. Now let us go to pathology and see what is happening in the kidney. Now, in acute pyelonephritis, because of infection, some areas of the kidney, they become infarcted. Should I repeat? Because of infection clogging the vessels. If you go and see in Robbins, you will notice this again. Because of infection clogging the vessels, you will see areas of infarction. So when we do Doppler, what do we see? We see areas of reduced vascularity, not increased, and everybody is answering the question wrongly because they are thinking acute pyelonephritis is an infection, there should be increase in vascularity, while acute pyelonephritis is characterized by areas of wedge-shaped infarctions in the kidney, and answer is areas of reduced vascularities are noticed. If you go back and see PGI MCQs, if you have time, maybe you do not have time, but let us see. You will see there is a question in PGI which was asked in the last year's exams as well. If I do IVP, dye will be taken up only in the viable renal parenchyma, only in the viable. So what is this called as? Striated nephrogram. Please remember, everything is interlinked, but you do not know the link. Because of areas of wedge-shaped infarct on IVP in acute pyelonephritis, you will see striated nephrogram, and on Doppler you will see areas of reduced vascularity. But your poor guidebook writers, they do not know this. So good for us, good for us. Now please remember a question from PGI, causes of striated nephrogram. Please remember acute pyelonephritis, infantile polycystic kidney disease, and medullary sponge kidney. Three causes of striated nephrogram are acute pyelonephritis, infantile polycystic kidney disease, medullary sponge kidney. Okay, is that memorable? Is that memorable? Okay. Now look at the question again. Now look at the question again. how easily AIIMS people have tricked people. They are now, and trust me, whenever everybody gets a question wrong, it is likely to be repeated in AIIMS. So May 2013 they have asked this question, and my gut feeling is they may repeat it this year. Why? Because it is wrongly answered by everybody. Answer is increased vascularity. You do not see increased vascularity. Do not see increased vascularity in acute pyelonephritis. You will see areas of reduced vascularity. Okay. Now look at this question again. Another question which is controversial according to some of the guidebooks. That is why I have taken from May AIIMS, just to tell you how to look at the questions. Which of the following stages of neurocysticercosis does not show edema on radiological imaging? Vesicular, colloidal, granular, calcified. Okay. Now let me tell you a few keywords about these questions. I'll teach you a few important keywords, because this is the topic that you do not read in medical school. Do not read. Okay. Although this is very important in AIIMS, now they are asking questions on this. Topic is neurocysticercosis on radiological test. How do I see this? There are 4 radiological stages of neurocysticercosis: vesicular, colloidal, granular, calcified. Now tell me. Okay. Now I'll teach you everything in simple language. Don't worry. Okay, what is vesicle? Vesicle. Remember from skin, vesicle, fluid filled vesicle. Sometimes you develop vesicle, fluid filled. So, cysticercus in vesicular stage would be fluid filled cyst. Now look at the simplicity of things. Examiner cannot hide from you. Everything is written. It is like a vesicle. And there is a scolex. So a new question will come. In which stage of the cysticercus do you see a cyst with a scolex? Vesicular. Okay. And the parasite is viable at this stage. Parasite is alive, viable. And you may see only minimal to nil edema. I'll tell you the reason also. Very little edema will be there in the surrounding brain. Inflammation, edema will be very less. Okay. Why? Because parasite is alive. The membrane surrounding the parasite is intact. Now, in the colloidal and the granular stage, parasite is dying now. Dying. Dying means not dead. In the process of dying. Now, think of it. This is a parasite and he is dying. What will happen to the clear fluid? Oh, you're not telling me at all. What will happen to the clear fluid? Clear fluid will become turbid. Turbid. Because the parasite is dying. You have studied all this so far. Turbid. So, what should I call it? Colloidal. Okay, now you understand the meaning of the word colloidal. Parasite has developed turbid fluid because the process of death has started, but it is not dying, not dead, dying. And what will happen to the cell membrane? Membrane of the parasite will become porous. It will start to leak. Dirty fluid of the parasite will come out. What will happen to the surrounding brain? Inflammation, edema, plus. And patient will throw a seizure as well. Can you understand? Brain becomes swollen, he will have an epilepsy episode. Then the parasite wall will become even more thick and it will retract. Granular. Now many of you might have gone to the hospital once in your life. If you remember, you must have heard of ring enhancing lesion in the brain. Which stage is this? Granular. Granular stage, parasite becomes like a ring. And then the parasite dies and becomes calcific, dead. And because the parasite is dead, there is no edema. Now can you understand this? Should I repeat? There are 4 stages: vesicle, vesicular, colloidal, granular, calcified. Calcified is the dead stage and there is no inflammation in the dead stage. Colloidal and granular are dying stages. In this the patient is symptomatic. There is extensive inflammatory edema in the surrounding brain. Vesicular stage is the cyst with a scolex stage. Cyst with a scolex. Scolex, you know, S-C-O-L-E-X, scolex. Okay. Now let us look at the question again. And let us see if we can help you here. Question is, which of the following stages does not show edema? Now answer is nodular calcified stage. Please trust me, some of your guidebooks are still giving the answer as vesicular, but in the vesicular stage you may see minimal edema. Calcified stage you do not see any edema. Maximum inflammation would be seen in the two stages, colloidal and granular. Usually colloidal is taken as the most symptomatic phase because that is where the inflammation starts. Most edema is seen in the inflammatory colloidal stage. Okay. Now let us see this question here. Causes of ring enhancing lesions in the brain. Very good question. Causes of ring enhancing lesion in the brain. Hyderabad. Yes, anybody who's asked this question is a potential AIIMS ranker. You can do clapping for you. Okay, let me tell you. Okay, Rohtak, just give me 1 second. Okay. Okay, I'll repeat everything. Okay, many questions are now firing in. Okay. Now maybe I should go back to the take note. I'll take note. Okay. Okay. Ring enhancing lesion in the brain are seen in. Very important question. You can get into AIIMS because you have asked a good question now. Good question can get you to AIIMS. Bad questions can, take you nowhere. Ring enhancing lesion is NCC, neurocysticercosis, tuberculoma. If they say AIDS patient, then you will mark toxoplasmosis, metastasis, brain abscess. Okay. Ring enhancing lesion in the brain causes are neurocysticercosis, tuberculoma, toxoplasmosis, metastasis, brain abscess. Okay. Now please remember one more question which is potential for your exam. They may change the ring to open ring. Open ring sign on MRI seen in demyelination. Okay, please remember. Ring means complete ring of dye uptake is seen in the lesion, that is seen in space occupying lesions which I have shown above. But if they say open ring, demyelination. Ring, NCC, tuberculoma, toxoplasmosis, metastasis, brain abscess. Okay. Now, cysticercus, when you see multiple calcified cysticercus in the brain, some books they will call it as starry sky appearance. Another question that I want you to remember is ultrasound starry sky appearance is seen in acute hepatitis. Okay. I hope your question is answered. Mysore. Acute hepatitis on ultrasound shows starry sky. NCC on CT scan, sometimes it is also called as starry sky. But another question, when you have cysticercus in muscle, suppose this is the limb and this is the bone. NCC, where will you see NCC cysticercus like this? Like this in the muscles. Cysticercus you will see. What is this called as? Rice grain appearance. Last year's All India question, DNB question, you might have seen. Rice grain appearance on X-ray, cysticercus. Because cysticercus is oriented along the long axis of the muscle, it is called as rice grain appearance. Okay, now let us look at the next question now. Okay. Now just two questions I think we have. Okay. These are two questions from AIIMS 2013 which I still feel have some description to be done here. That is why I want to do this with you. Question is, a 8-year-old child has pain, mental retardation. There is a lesion in the kidney and lesions in the liver. Density is -50 to -80 Hounsfield. What is the diagnosis? Now please tell me from your knowledge so far, -50 to -80 Hounsfield on CT scan indicates fat. Fat containing kidney lesion could be angiomyolipoma. Can we see angiomyolipoma in liver? Yes, angiomyolipomas can be seen in liver as well. And look at this now, what are they saying? Liver angiomyolipomas, kidney angiomyolipoma, mental retardation. Together this is equal to, I'm sure all of you know, tuberous sclerosis. But I will give you something else. Okay, I will give you some other questions here on tuberous sclerosis. Quickly remember, because this is my prediction that this would be likely be asked in the next AIIMS. Tuberous sclerosis, please remember, what do we see in brain? We see hematomatous area in the cortex of the brain called as cortical tubers. You will see subependymal calcific nodules which are called as below the ependyma, below the surface of the ventricle, calcific nodules which are called as candle dripping. Very important question. Candle dripping in the brain, tuberous sclerosis. In the area of foramen of Monro, you will see a brain tumor which was asked in 2011 AIIMS, which is foramen of Monro. What will you see? Subependymal giant cell astrocytoma. Let me repeat everything again. Tuberous sclerosis, 3 questions from brain. Please remember, number 1, cortical tubers. Are these neoplastic or hamartomatous? Hamartomatous area. Second, subependymal calcific nodules, also called as candle dripping. Third, you will see a subependymal giant cell astrocytoma at the foramen of Monro. Okay, what will you see in tuberous sclerosis in heart? You will see cardiac rhabdomyomas. What do we see in kidney? Angiomyolipomas. Angiomyolipomas. What do you see in, okay, tuberous sclerosis? What do you see in lungs? What do you see in lungs? In cardiac rhabdomyomas, renal angiomyolipomas, what do you see in lungs? What do you see in lungs? Lymphangiomyomatosis. Lymphangiomyomatosis. What is this? Now let us understand this and you will understand something very important. Lymphatic cysts lined by smooth muscle in the lung. Let me draw this for you. Okay, we are sorting it out, don't worry. Okay, look at this, lungs, and there are cysts lined by lymphatic cyst lined by muscles. So what is the X-ray appearance of lymphangiomyomatosis? Honeycomb. So what will you see in lungs in tuberous sclerosis? We may see lymphangiomyomatosis, which is called as honeycomb appearance of the lung. Which is called as honeycomb appearance of the lung. Okay, Hyderabad, you are confusing something. Let me just show you something very important. I am saying lymphangiomyomatosis. Okay, and you are saying lymphangitis. Okay, you are saying lymphangiocarbcinomatosa. Okay, so you are saying lymphangitis carcinomatosa. There are two different things. Now, when you see similar words, you get confused. Don't get confused. Lymphangio means lymph, muscle. Here, lymphatic cancer. Cancer in the lung lymphatics is different. Okay, Hyderabad. Okay, so causes of lymphangitis carcinomatosa are, what is lymphangitis carcinomatosa? Certain cancers spread by plugging the lymphatics. Okay, certain cancers spread by plugging the lymphatics. Which are these? This is the mnemonic that you need to remember. Cervix, colon, stomach, breast, bronchus, pancreas, thyroid. Very important PGI question. Okay, very important PGI question. Larynx. Okay, should I repeat? What is the mnemonic of lymphangitis carcinomatosa? Certain cancers spread by plugging the lymphatics. Cervix, colon, stomach, breast, bronchus, pancreas, thyroid, larynx. Should I repeat? Cervix, colon, stomach, breast, bronchus, pancreas, thyroid, larynx. Okay, they are looking at it. Okay, we will reshare the thing. Okay, share the PowerPoint. Okay, let us come to the last question on radiology here. Okay, what is the last question that you need to look at? A patient has cough with fever. X-ray, there is a homogeneous opacity silhouetting the right heart border with ill-defined lateral margins. What is the most likely diagnosis? Pneumonia affecting the medial lobe of the right middle lobe, pneumonia affecting the superior segment of the right lower lobe, pneumonia affecting the anterior segment of the right upper lobe, loculated pleural effusion. Now what I want you to know here is, look at the, you will read this question in total and you will not get the answer. Okay, only look at a few words, everything is okay. They are saying fever, cough. Okay, no, not of any use here. You cannot answer on that basis of this. They are saying opacity silhouetting the right heart border. Which lobe of the lung silhouettes the right heart border? Answer is middle lobe. Very often asked question. Middle lobe is known to obscure the right cardiac border, but please remember middle lobe has two segments, a medial segment and a lateral segment. Medial and a lateral segment. Please remember, only the medial segment pathologies will obscure the right heart border. Medial segment will obscure the right heart border. Okay. Now, but I want you to know second thing, one more thing. They are saying ill-defined lateral margins. That means the medial margin is silhouetting the heart. The outer margin is not well seen. This is typical of pneumonia. Pleural effusion will always have sharp margins, even if it is in a fissure. Okay. Mumbai, don't worry. We will again, broadcast this with you. Don't worry. Okay. We are recording this also. Don't worry. We understand. Okay. Patient has fever, cough, homogeneous opacity silhouetting the right heart border with ill-defined lateral border. Ill-defined border means pneumonia. It cannot be pleural effusion. Pleural effusion has sharp borders, and silhouette sign is seen in middle lobe pathologies. So answer is medial segment of the right middle lobe pneumonia. Medial segment of the right middle lobe pneumonia. Okay. Mumbai. Okay. You want me to repeat everything? Okay. Don't worry. Mumbai Center. If you have missed something, don't worry. We are recording this. We'll share this with you again. Don't worry. Okay. Don't worry. We're recording this as well. Just for the people who missed anything, I will run through all the questions in once last. Okay. Young female lactating, painful lump. What is the answer? We are thinking of abscess. What is the answer? Ultrasound. Fast is focused assessment with sonography in trauma. But if the next time they will say E-fast, answer would be extended fast. Increased blood flow means plethora, which is characterized by 3, but it does not show curly B lines, which is seen in edema. Striatal and asymmetric white matter abnormality in a 14-year-old boy with movement disorder is Wilson's disease. Okay. Road traffic accident and stratosphere sign on M mode is pneumothorax. Parasagittal hematoma with fetal distress, sagittal pregnancy, everything they have written, have to think of superior sagittal sinus thrombosis. Let me repeat once more. Acute pyelonephritis, you will not see increased vascularity, you will see reduced vascularity. Calcified stage does not show edema on radiological test. Angiomyolipomas can be seen in kidney and liver both in tuberous sclerosis. And silhouette sign is associated with middle lobe pathology, particularly medial segment. Now some of you might have missed, okay, Mumbai, don't worry. Whenever we have a break in between, we will repeat the entire program. Don't worry. Whenever we have a break, we'll repeat it. Okay. We are all looking at every problem if you are facing, and we'll repeat everything. We're recording it. Don't worry. Okay. Thank you very much, and I wish you all the best for upcoming games. Thank you.